Here we are presenting a case of atypical sweet syndrome that initially presented as cellulitis. 67-year-old female with a past medical history of multiple sclerosis and chronic kidney disease presented with worsening erythema and edema of bilateral lower extremities. Patient had been recently diagnosed with cellulitis by her PCP and was being treated with etrionam and vancomycin. Over the next few days, she had intermittent low-grade fevers and her cellulitis showed no improvement. She also began having purulent discharge in bilateral eyes and was given antibiotic eye drops for suspected bacterial conjunctivitis. Labs were remarkable for worsening leukocytosis, neutrophilia, and thrombocytosis, as well as elevated ESR and CRP. Patient also developed diffuse tender pustular lesions throughout her body. The lesions became hemorrhagic bullae, which burst and turned into ulcers. Extensive infectious disease and autoimmune workup was negative. Right forehead punch biopsy showed marked neutrophilic inflammation suggestive of sweet syndrome. High-dose Solumedrol was started with clinical improvement and eventual resolution of lesions. Figure 1a shows the blanching erythema in the lower extremities that the patient presented with initially that was thought to be cellulitis. Figure 1b depicts the formation of tender pustules on the eyelids, nares, around the mouth, and Figure 1c shows the hemorrhagic bullous formations on the left hand. Figure 2a and b is the histologic section from the punch biopsy taken from one of the lesions on the forehead, which shows squamous epithelium with reactive changes surrounded by a dense neutrophilic infiltrate that is consistent with a diagnosis of acute neutrophilic dermatosis. Sweet syndrome is an uncommon inflammatory disorder that is characterized by fever, leukocytosis, painful cutaneous plaques, and possible systemic involvement. Proposed pathogenesis include abnormal neutrophil function, altered expression of inflammatory effector molecules, and a genetic predisposition. Sweet syndrome is a diagnosis of exclusion. Infectious and inflammatory etiologies need to be ruled out first. There are 3 subtypes of sweet syndrome, which include classical, drug-induced, and malignancy-associated. Drugs commonly implicated in sweet syndrome are granulocyte colony stimulating factor, tretinoin, Bactrim, and azathioprine. 85% of malignancy-associated sweet syndrome is linked to hematological disorders, most frequently to acute myelogenous leukemia, but are also seen in patients with Hodgkin disease and polycythemia vera, as well as patients with solid tumors. To diagnose classical sweet syndrome, both of the major and at least 2 of the minor criteria are required for the diagnosis. The major criteria include 1. Painful plaques or nodules, 2. Fever greater than 38 degrees Celsius. The 4 minor criteria include 1. Neutrophilic infiltrate, 2. Malignancy, inflammatory disease, or recent URI or GI infection, 3. Response to corticosteroids or potassium iodide, 4. Elevated ESR, CRP, and leukocytes. Our patient met both the major and minor criteria for the diagnosis of classical subtype. Typical presentation is tender red papules on upper extremity, face, and neck. This case was unique because of the hemorrhagic bullae appearance of the lesions, as well as the involvement of the oral mucosa, which is reported in only 2% of classical sweet syndrome cases. The diagnosis of sweet syndrome is challenging due to the variant presentations and the fact that it is a diagnosis of exclusion. Our goal is to raise awareness of this uncommon condition with the hope of reducing delays in diagnosis and treatment and ultimately improving morbidity and mortality for future patients. Thank you.